Hi, my name is Arj Jasani, and today I'm going to be presenting my Pecha Kucha presentation on healthcare serial killers and the challenges that are faced to identify them in forensic pathology. So let's see what's a healthcare serial killer. A healthcare serial killer is a healthcare professional who intentionally kills two or more patients in a caregiving environment for reasons that are not related to euthanasia or physician assisted suicide. Victims of healthcare serial killers are usually vulnerable, often very young or old, but they're not usually terminally ill. And the choice of weapon used by these people are usually injected medications or suffocating the victims. The challenges that we face in identifying these serial killers due to Coroner's Act are that only sudden and unexpected deaths in the long-term care facilities are to be reported through the IPDR form, which is very subjective when it comes to its definition. And then it is the coroner's call to either proceed with the autopsy or not. Another challenge is that most of the deaths that occur in a hospital under doctor's supervision rarely go through a medical legal autopsy as they do not come under Coroner's Act. Here we can see a set of data published in the Long-Term Care Public Inquiry after Elizabeth Wettlaufer case, which shows that the number of LTC home death investigation and post-mortem examination is declining each year. Now we are going to look at understanding the challenges that we face during different steps of a medical legal autopsy, beginning with the crime scene and circumstances to ancillary tests. And we are going to look through them using the case of Elizabeth Wettlaufer. So just a brief background, Elizabeth Wettlaufer was a nurse convicted of 8 counts of first-degree murders, 4 counts of attempted murders, and 2 counts of aggravated assault. She actually confessed to injecting the LTC residents with insulin overdose. So the challenges at the first step are that the long-term care residents had other comorbidities and their death was expected. So the coroner was sent an IPDR form with no red flags. And many of the victims Wettlaufer targeted had a history of hypoglycemic episodes. Also, most of the LTC facilities have no tracking for insulin and there is no surveillance in the medication room where insulin or other medicines are kept. The IPDR form is also flawed as it has no space for concerns that can raise contextual red flags. The challenges at step 2 of external examination is that usually with these patients there are no signs of external trauma and the needle marks from injection are common for these patients who are administered many injected medications daily. So at step 3 during internal examination, these patients have hypoglycemic encephalopathy which might appear as stroke with subtle brain changes and therefore it is hard to detect that death could have occurred due to insulin overdose. Coming towards the ancillary testing, it is something that is not always conducted unless there is a suspicion of toxicological death, and in this case insulin is not covered in the toxicology test panel as it is a normal lab test. Another challenge is that the window of detection for many toxic substances is very small and the specimen needs to be frozen immediately, which is not done usually. Also, blood glucose levels drop rapidly after death and hypoglycemia can be caused by other factors. The solutions include redesigning the IPDR form to be more evidence-based and the development of a standard protocol for autopsies performed on elderly and children, as well as the inclusion of surveillance in medication room of LTC facilities and hospital.